Hey guys, today I'll be talking about atopic dermatitis. Before I start, I'll just talk a little bit about what dermatitis is. So dermatitis is a skin inflammatory condition involving the epidermis and the dermis. It often results in erythema, papules, blisters, pruritus, flaky skin, and open sores that form into crusts. These develop at the same time or progress from each other. Histological features can include spongiosis, parakeratosis, acanthosis, lymphocytic and granulocytic infiltrates. There are different types of dermatitis, however today I'll be discussing atopic dermatitis. Atopic dermatitis is a chronic inflammatory skin condition which has an early onset, usually presenting in early infancy, with up to 20% of children and 10% of adults affected in developed countries. This disease has periods of remission and exacerbation. Clinical manifestation includes dry, pruritic, port-a-fine, excoriated patches that can affect any area of the body, although distribution and morphology commonly depends on age. Atopic dermatitis also causes sleeplessness, compromised mental health, decreased work productivity, and overall reduced quality of life. The pathogenesis. So atopic dermatitis is a systemic disorder, and skin barrier defects as well as immune dysregulation contributes to the onset. It is also associated with other atopic and allergic conditions such as asthma and atopic rhinitis. Pathological changes that can occur with atopic dermatitis involve cutaneous infiltration of immune cells, mainly T lymphocytes, and epidermal edema. There is also an increased likelihood of cutaneous infections such as Staphylococcus aureus and viruses such as herpes simplex. Moreover, there is a higher incidence of cutaneous infections in children such as respiratory infections, streptococcal pharyngitis, recurrent otitis, and urinary tract infections. Genetic risk factors, innate and adaptive immunity dysregulation, as well as environmental factors contributes to the pathophysiology of atopic dermatitis. D helper 2 skewed immune responses and exaggerated IgE responses to allergens also involved in the development. Additionally, barrier dysfunction is also believed to contribute to atopic dermatitis. Damage to the epidermal barrier contributes to greater permeability of the epidermis, increased inflammation, and percutaneous sensitization to allergens. The skin acts as a barrier against environmental stresses and dehydration. In the stratum corneum, apoptosis of keratinocytes occurs, causing flattening of corneocytes in the lipid matrix. So filaggrin normally binds to keratin intermediate filaments and is the main source of many components of the natural moisturizing factor. This maintains stratum corneum hydration and its pH. Skin barrier integrity is regulated by acidification by filaggrin metabolites. Filaggrin gene mutations result in a decrease or loss of filaggrin synthesis and are known to contribute to the onset of atopic dermatitis. Several pathways are affected by a lack of filaggrin, impacting skin barrier function, such as interference of keratinocyte differentiation, weakened corneocyte integrity and cohesion, decrease in tight junctions, reduced water retention, decreased lipid production, and a higher chance of cutaneous infections. The stratum corneum has an acidic pH, however lowered natural moisturizing factor levels results in an increase in pH with an allied dose-dependent effect. The highest pH levels are detected among homogeneous filaggrin mutation carriers. pH-sensitive serine proteinases are activated by this increase, causing corneodesmosomes to break down and initiation of interleukin 1A and interleukin 1B. The production of ceramides relies on the presence of an acidic mantle. Ceramides, which are essential lipids located within the stratum corneum intracellular lipid matrix, are involved in skin barrier integrity. However, lack of filaggrin is believed to alter the lipid profile, with high levels of free fatty acids in filaggrin constructs contributing to a disorganized intracellular lipid lamella and increased permeability. So some of the factors that can contribute to atopic dermatitis include mechanical damage such as frequent scratching using detergents and exogenous proteinases including dust. Repeatedly washing of the skin also causes mechanical damage. Climate is also a contributing factor which plays in a role in impairing skin barrier with an increased prevalence of atopic dermatitis in autumn to winter births, indoor heating, decreased humidity, lower mean temperatures, reduced ultraviolet index, and greater precipitation is also believed to increase the likelihood. Immunological dysfunction. Atopic dermatitis cutaneous inflammation is caused by impaired epidermal barrier integrity. Filigran deficiency is linked to increased penetration of percutaneous microbes and allergens, as well as decreased tolerance to irritants and haptens. So activation of the innate immune system, such as pro-inflammatory cytokines and chemokine release by keratinocytes, as well as antigen presentation by Langerhans and dendritic cells, are known to contribute to atopic dermatitis and its inflammation. Microbiome. Atopic dermatitis alters skin bacterial microbiome composition, contributing to a compromised skin barrier. Several studies have found that Staphylococcus aureus contributes to higher atopic dermatitis severity. Increased Staphylococcus aureus colonization leads to reduced skin barrier function and integrity, as well as increased transepidermal water loss. Additionally, inflammation is triggered by staphylococcal peptides and their superantigens. Staphylococcal delta toxin produces degranulation of mast cells, which during apoptosis of keratinocytes occurs from alpha toxin. Staphylococcal enterotoxins activates T cells, and inflammation is controlled by specific staphylococcal surface proteins. So some management strategies that can be include the application of moisturizers with emollient, occlusive, and/or humectant ingredients to retain moisture to the skin and improve a defective skin barrier. This may prevent it early on or delay atopic dermatitis development. Topical moisturizers can reduce transepidermal water loss and xerosis. Emollients such as glycol, glycerol stearate, and soy sterol maintain skin hydration and soften the skin. Occlusive agents including petroleum, dimethicone, and mineral oil provide a layer to prevent water evaporation from the skin, while humectants such as glycerol, lactic acid, and urea draws and retains water. Neutral to low pH non-soap cleansers and that are fragrance-free and hypoallergenic should also be used. Topical corticosteroids, which have an effect on immune cells, including T lymphocytes, macrophages, dendritic cells, and monocytes, reduce inflammation by interfering with antigen processing and pro-inflammatory cytokine release. And finally, topical calicirin inhibitors prevent calicirin-dependent T cell activation, which in turn inhibits the release of cytokines which are involved in inflammation. Thank you.